Okay, everybody, it is 11:30. We are going to get started just because we have a lot of content to cover today. So welcome everybody to our autumn series, Injury Prevention Learning Series and sessions. Today, if the link on the code, my brain's going to work today, I apologize. The QR code that's on the slide in front of you is actually the link to all of our previous sessions. So if you're interested in watching any of our previous sessions, from back when we started, you can scan that code and it will take you to all of our videos that we have. So today, in honor of Domestic Violence Month, myself and Allie Evans are going to be presenting on IPV, which is Intimate Partner Violence Recognition and Resources. I know that some of you have joined us in the past for our Intimate Partner Violence Learning Series. This is going to have a lot of the same information in it. But again, we're going to go through it fairly quickly. So again, welcome to the session. Just to let you know, I apologize, I did not change the top of that slide. This is not trail running safety. So intimate partner violence, we have no disclosures to let you guys know of. This does offer nursing contact hours. So to be able to be eligible to get the certificate for nursing contact hours, you do need to participate in all of the polling questions today. Allie will kind of introduce that. If you're not able to use the platform that we have put in there, because it won't be your traditional Zoom polling, you're going to go ahead and use the chat. So again, this is certificates, so it's not the same call-in as our trauma ground rounds and EMS ground rounds, and you will have those within a week once we get done with everything. Again, like I said, if some of you have been part of our Intimate Partner Violence Primary Prevention Series, this QR code will take you again to all of those recordings. So anything that we talk about today that maybe you want to learn more of or go more in depth, because again, we are just skimming the surface today, go ahead and scan that code and it can take you to our YouTube channel and you can watch any of those sessions going more in depth. And again, myself and Allie are available for trainings, for staff meetings, any sort of trainings that you have like that, that we are more than happy to come and put on some trainings. We always like to put out there that we have our trauma and EMS grand rounds. I am planning for 2022 trauma and EMS grand rounds. So if you have a topic that you really think would be beneficial that you would like to learn about or like us to put on, please email me and let me know. You can see my email there on this slide as well. So our trauma grand rounds is going to be the November 18th. So it is the third Thursday every other month. We have adjusted the time. So the time is now 7:30 a.m. instead of 7 a.m. Hopefully that will help for some of you that change shifts at 7 a.m. to be able to have that time to join in with us. Our EMS ground rounds are the second Wednesday every other month. So our next one is going to be on December 8th. Our trauma ground rounds coming up in November. Again, it is provider focused, hospital focused, and it will be on airway management. I'm frozen. There we go. Okay, so November 18th is also National Injury Prevention Day. We are trying to get some buildings and some community members to go green, shine the light on injury prevention. This is a national day that was brought into Congress now that November 18th will be National Injury Prevention Day from here on out. So you can read that. There's the link down there if you want to check out the website. If you want to be involved in promoting in National Injury Prevention Day, again, let me know. My hope is I can get the Legacy Bridge on campus lit up green. And then we're going to collaborate with our other injury prevention colleagues in the local area. Again, we always have our podcast. So Adventures in Injury Prevention, Safely Exploring Utah's Great Outdoors. Those are all on Apple and Spotify. So I would love it if you guys would follow us, listen to some of those. Again, we love to take ideas. If you want to be part of our podcast, if you want to present on something in injury prevention, if there's something that you're passionate about that can focus on that, especially because we have so many great outdoor activities, please let me know and we can get you set up with that. And we always like to also promote the Crisis Standards of Care site. So this is through our burn center, through Annette Matherly, which is Annette Newman, and I'll still call her Annette Matherly, I think, till the end of days. But you can sign up on crisisstandardsofcare.utah.edu. That's great. Got some great CME opportunities. They talk about wound care. They talk about neck fash. They talk about burns. A lot of great information on that site. So I think it's a great opportunity to go ahead and sign up for that. That does remind me that we thought we had our website with all of our recordings for trauma and EMS ground rounds. The little glitch worked out, but found out that it's not working out yet. So once we get that site up and running again with all of our new trauma and EMS ground rounds, I will send you guys that link. But you can still go to the trauma education site on the University of Utah Health and see all of the ones, but they're 2 years old. So that'll come up soon. All right, so I'm actually going to let myself and Allie just introduce ourselves. I did not have slides for us. So I'll introduce myself real quick, and then I'm going to turn it over to Allie. She's going to take over. So my name is Jamie Troyer. I'm the Injury Prevention and Outreach Coordinator for our trauma program here at the U. I have been in this position now for 2 years. I came from the emergency department at the U, where I spent almost, 10.5 years working in there. And then I have an EMS background. So I worked at the prison for 8 years. They let me out for good behavior. And I worked for EMS. I worked for Unified Fire paid call for 10 years. So all I really know is EMS. I love injury prevention. And right now I'm kind of being spoiled working from home with my 3 dogs. That's my favorite thing to do. So I'll turn it over to Allie.
Thanks, Jamie. My name is Allie Evans. I'm the Clinical Education Outreach Nurse for the Office of Network Development and Telehealth. My background is the emergency department, actually with Jamie, where I was a member of the Emergency Response to Violence Committee and really started learning a lot about intimate partner violence and some of the content that we're going to present to you today. So I'm just going to take a second and share my screen.
And while she's doing that, just to let you guys know, if you have any questions, feel free to come off mute or put it in the chat. I will be monitoring the chat as well. So we like it to be interactive. So please share it with us when we're doing this.
Great. Thanks, Jamie. All right, let's go ahead and get started. So today, Jamie and I are going to talk about intimate partner violence and strangulation for the Trauma Injury Prevention Series. We have no financial disclosures, but we did want to note that because domestic violence is not strictly heteronormative trend, meaning that all genders can perpetuate and become victim to domestic violence, we have made a conscious effort to use gender neutral pronouns in many of our materials that we'll present today. But in recognition that 85% of victims of domestic violence are female, there are some instances where gendered pronouns are used. Here are our objectives. And today we're going to use a tool called Slido. So if you haven't used this before, what you'll need to do is take your cell phone and scan the QR code. If you don't have a cell phone, no big deal. You can just type your answers into the chat. But this is just a way that we like to keep our audience interacted throughout the presentation. So I'll give you just a few seconds to do that. And we're going to hop into our first question here. So how many hours of IPV training do you get per year? So go ahead and answer that on your phone if you can. And then if you can't use Slido on your phone, just throw that number into the chat for us. And this is how you'll also get your contact hours today. And Jamie, I'll have you watch the chat, but we've got 7 people who have answered so far.
Yep, and we have 2 in the chat. So 1 to 3, 5 plus, about 4 to 6, 5. So we've got some coming up in the chat.
All right, great. So looks like 1 to 3 hours of IPV training per year is kind of our average right now. And that'll be helpful as we go through our presentation. All right, so what is IPV? Intimate partner violence. So intimate partner violence is often interchanged with domestic violence, and I'll talk about both of them. Domestic violence refers to violence among people in a domestic situation. So this can include a spouse or a partner, but also siblings, parents, aunts, uncles, cousins, anyone who's related to you and living in the house. Intimate partner violence is more specific in describing violence perpetrated by a partner in a romantic or dating relationship. So just to let you know, these phrases are often used interchangeably, and we're going to use them interchangeably as we discuss it today. Next question, which of the following are examples of intimate partner violence? All right, yes, exactly. So all of them. We'll go through them really quickly here. Physical violence is when that person tries to hurt a partner by hitting, kicking, or using some type of physical force. Sexual violence is forcing or attempting to force a partner to take part in a sexual act, which includes sexual touching, a non-physical sexual event like sexting, when the partner doesn't want to or cannot consent. Stalking is a pattern of repeated unwanted attention or contact by a partner that causes fear or concern for one's own safety or the safety of someone close to the victim. And psychological aggression is one that I really want to highlight. And this is the use of verbal and nonverbal communication with the intent to harm another person. This could be mentally or emotionally, and they're really trying to exert control over another person. So keep in mind that this could be financial control if a partner takes away money, or movement, control of movement if they take away the vehicle of the person in this situation. And I also wanted to talk a little bit about atypical presentations. So these are the patients that come in to the hospital or that you see pre-hospital that have pregnancy problems. And you wonder, is this the desired or consensual pregnancy? They may have frequent UTIs, suicidality, intractable abdominal pain, STIs, frequent falls or injuries, a changing story when speaking about their injuries, and trouble maintaining a linear thought process. And moving right along into our next question, what are the consequences of intimate partner violence? We have physical injuries, death, negative health outcomes, increase in risky behaviors, and societal costs. Great. So actually, all of these are consequences of intimate partner violence. So according to the CDC, we'll talk about physical injuries first. 35% of female IPV survivors and 11% of males experience a physical injury related to intimate partner violence. For 1 in 5 homicide victims are killed by an intimate partner, and we'll talk about this a bit later. Negative health outcomes are very common, and these include a range of conditions affecting the heart, digestion, reproduction, muscles and bones, nervous systems, and many of these health outcomes become chronic health problems. Survivors can also experience mental health problems such as depression and PTSD. The increase in risky behaviors goes up, so higher risk for engaging in behaviors like smoking, binge drinking, and risky sex. And societal costs increase. So the lifetime economic cost associated with medical services for IPV-related injuries, plus the loss of productivity from paid work, plus criminal justice and other costs, was $3.6 trillion. So just to put that into perspective, the cost of IPV over a victim's lifetime was over $100,000 for women and about $23,000 for men. Just to talk a little bit about the national statistics, IPV is very common. About 1 in 4 women and 1 in 10 men will experience contact sexual violence, physical violence, or stalking, or some kind of intimate partner violence related event during their lifetime. And Jamie is going to talk a little bit about false reporting and EMS. You want to jump in?
Yeah, I'll just talk about that. Even it's not just with EMS, false reporting. I think a lot of people have the stigma or the myth for whatever reason that false reporting is high. And it is actually only between 2 to 10% of all reporting is false. It is very rare. It doesn't usually happen. What really happens is people don't report. So you have in 2017, 40% of the people had reported an intimate partner violence. And this was according to a national violence survey that was sent out. And it was down to 25% in 2018. So people are reporting less. But I want you to think about those numbers. Those are people that are actually admitting that this is a problem or that this has happened to them. So these numbers are skewed because you have many people that are victims of violence or victims of intimate partner violence that are not reporting that at all. So I would guess that these numbers are even higher of people that are not reporting. But it is concerning that the amount of people who are not reporting is lower than what we would like to see. So we'll talk a little bit more about that when we talk about screening and statistics and things like that.
Thanks, Jamie. And then just to talk a little bit about Utah statistics. So remember that national statistic was 1 in 4 women. And in Utah, that number is actually higher. So it's 1 in 3. Again, anyone can be a victim of domestic abuse, but 1 in 3 women in the state of Utah experience IPV in their lifetime. The majority of DV victims are female. Just a few statistics here. So since 2000, 42% of adult homicides were domestic violence related, and more than half of the homicides were perpetrated by a family member, cohabitant, or intimate partner. At the time, only 2%, of these victims had a protective order in place at the time of their death, and children witnessed 22% of DV homicides. And then men were the perpetrators in 88% of DV-related murders. And Jamie's going to talk a little bit more about fatalities as well.
Yeah, so just looking about fatalities, that's the one thing we worry about. And obviously that is a hot topic right now. And very sad to think that, something that makes the news or an intimate partner violence relationship or death in the news is what brings our attention to the fact that this does happen. So again, think about the numbers here that and this is from the Utah Department of Health. So the intimate partner violence, domestic violence report, and this is a 2020 report, but this only reports up to 2016. So just so you guys know those numbers. And I have a feeling those numbers would also be higher. But again, 59.9% of those victims were female that are killed in a relationship. So one of the things we want to talk about is we want to get to where they're not at this point. And then again, I like to point out that 66.9% of IPV related fatality victims died by homicide. And then thinking about the fact that 33.1 died by suicide. So thinking about our patients that come in that are feeling suicidal, that maybe there are frequent flyers, that they're there on a regular basis. Is there suicidality and is there thought because they're in an unhealthy relationship, because they are a victim of domestic violence? Many things that can add into this, do they have those adverse childhood experiences? We talked about this in our IPV, resiliency is different for every person. So even though, Allie might be super resilient to something and I'm not, it's just the way life goes. And it doesn't mean that there's anything wrong with either one of us. It just means that we respond differently. So I really like to point out that number, that even though it's twice the amount that are killed by homicide, that 33% is still dying by suicide. And we'd like to impact all of those things as well. And then again, 85.9% of the homicide victims are female. So thinking about this, we do talk about this as it is. The stigma, and again, the social determinant of health, the thing that we're trying to break the cycle of is that this is a woman problem or a female problem. this is a problem for everybody. If you've talked to or listened to one of our previous presenters, Marty Liccardo, says that, the majority of the perpetrators are male, but that doesn't mean that all males perpetrate violence. So we need to get everybody involved in this conversation to start bringing these numbers down, not just the 1 in 3, but again, the homicides and the suicides. So this needs to be something that's on everybody's mind as we teach, just as a society and a community.
Thanks, Jamie. And another thing that I wanted to bring up today is talking about the shadow pandemic. So this is that pandemic within a pandemic, and it's looking at intimate partner violence with the lens of COVID-19. So the numbers that Jamie and I referenced before regarding national statistics and Utah statistics were all researched before COVID-19 even was a thing. So since the pandemic, violence has intensified. We don't quite have the exact numbers yet because this is still an emerging topic, but we do know a few things. And one is that the stay-at-home orders left IPV victims trapped with their abusers. DV calls initially decreased. Many think that was because the IPV victims couldn't safely connect with the resources, and then they increased. They also had other exacerbating factors like security, health and money worries, cramped living conditions, movement restrictions, and deserted public spaces. Domestic violence shelters are reaching capacity, or they can't take new victims due to lockdown and social distancing measures. And then another thing that I want you to think about is that the increase in telehealth visits can be great for outreach and to get people to the doctor, but how do you screen for IPV during a telemedicine appointment? What if the abuser is also in the room and you just can't see them on the other side of the screen? So these are just things to think about as you continue to provide great patient care moving forward in the time of COVID. So let's talk a little bit about prevention. So this is the prevention triangle. You might have seen this before, but really, as EMS and in-hospital providers, we usually see the results of violence. So we're responding to the violence after it's happening rather than 100% working to prevent it from happening in the first place. So what we're doing normally is called secondary prevention. And that's that immediate response after the violence has occurred, that immediate life-saving intervention. But primary prevention focuses on the efforts to stop violence before it even happens. So what is one of the biggest risk factors for intimate partner violence? Intimate partner violence. So how do we break this cycle? How can we stop IPV before it starts? So I want you to take a second and just brainstorm. So this Slido question, how can we stop IPV before it starts? Just start typing in some phrases and examples and things you think that we can do. Again, use the chat if you don't have the Slido function today. Education and awareness, those are two really great ways. That's what we're doing now. Education in grade schools, becoming aware, paying attention. This is great. Education's a huge one. Asking questions, we'll talk a little bit about that. And I love this comment, education in grade schools. We'll touch on this a little bit later, but ACEs, or adverse childhood events, is a concept that increases, the more ACEs you have, the more of an increased risk you have for intimate partner violence. And unfortunately, we don't have the time to go into that today. But actually, Jamie, if you could grab that ACEs resource and throw that in the chat, I think that'd be great.
I'll get that
on time. Great. Open our mouths and talk. I love it. This is all awesome. Advertising resources. Yes. All right. So this document here is a framework or a technical package created by the CDC, and it really just outlines approaches to prevent intimate partner violence. So they're all meant to be used together. And like I said, a lot of these will focus on things that you can do earlier for children. And like I said, we can't really focus on ACEs today, but it's a really good resource and something for you to look up maybe after this lecture. So teaching safe and healthy relationship skills, engaging influential adults and peers, disrupting developmental pathways towards partner violence, creating protective environments, strengthening economic supports for families, and supporting survivors to increase safety and lessen harms. So we're really going to focus on that bottom tier, supporting survivors to increase safety and lessen harms. That's victim-centered resources, first responder and civil legal protections, patient-centered approaches, and then the treatment and support for survivors of IPV. So research shows that the experience the survivor has with the first disclosure of their attack can dictate the general course for future encounters, as well as predict the likelihood and severity of PTSD, depression, and other physical and mental sequelae of assaults. So really what this is saying is that the first experience that someone has when they tell their story is really going to affect how and when and why they tell future stories. So what we want to do as healthcare providers is start by believing. And this is a national campaign that talks about your response when someone tells you that they've been in a situation with their intimate partner. Next, of course, we want to treat immediate life-saving injuries, assess danger, report to law enforcement if needed, and then provide resources. And Jamie, I don't know if you want to talk a little bit more about the Start by Believing right now.
Yeah, I'll jump in and just throw some stuff out there. So Start by Believing campaign, if you get on there at any point in time at startbybelieving.org, it's got some great stories on there that talk about especially these victims who've told their story multiple times. And part of that is if there is a negative reaction, like a negative reaction to their disclosure is 100% worse. They would rather have no reaction than a negative reaction when they tell their story. And again, it is just changing that cycle and changing a mindset and being aware of our own implicit bias when we're responding to somebody about thinking that making sure that there's no blame, making sure that there's no disbelief. And if we are not in a position to be able to respond that way, then have someone else come in and talk to them about it. There's nothing wrong with that. There's nothing wrong with not being in the right headspace to have that conversation. It's an awkward conversation. It's a hard conversation to have to begin with. But if you're not in the right headspace, that maybe you're having a rotten day, you have your own stuff going on, it is actually better to have somebody else come in and ask those questions and put that form of trust. And again, start by believing these victims. And then hopefully we can get those numbers of reporting to go up. I saw another study that they did in colleges across the state where the University of Utah actually had the highest number of reports. Take that good or bad. To me, I take that as good because at least I think they feel safe enough to report this violence, domestic violence or dating violence, something like that. So I did actually like to see that number, even though I don't like to see that number on the same side. But our response, and again, it is a hard thing to look in the mirror at our own implicit bias and make sure that when we respond, that it is by believing. And again, I always encourage people to get on that site and just watch some of the stories and see the impact that you really have. I think hearing those survivor stories and being able to see other people's, the victims of this and their response when you have a positive versus negative response is huge. And I think it only helps us learn.
Thanks, Jamie. And as you just said, language is everything. So one way that we can help with the Start by Believing campaign is actually by implementing trauma-informed care. So trauma-informed care acknowledges the need to understand a patient's life experiences in order to deliver effective care. And this improves patient engagement, treatment adherence, health outcomes, and then even provider and staff wellness. So it's really changing that question from what's wrong with you to what's happened to you. And we're just going to watch a quick, about 4-minute video And this really details trauma-informed care in a way that gets the message across beautifully. So this is from the Center for Healthcare Strategies. I'm just going to play this video here.
How can you ask someone about their body? How can you ask somebody about their mind and not recognize their experiences in the world as they're living in that body, as they're thinking and having that mind? It really is about recognizing people as whole beings and not just body parts. To me, that's trauma-informed care.
The majority of illnesses and conditions that people are treating in primary care settings are trauma-related.
There are things going on inside that you cannot visibly see, that if you don't ask about, it's maybe a barrier to the actual care that the healthcare system wants to provide.
We want to give people good care, but we want them to thrive. Not just be healthy, but thrive. And it's very hard to thrive in this community.
I experienced patients that were behaving in ways that were really stressful, cursing, yelling, really heightened emotions at the front desk, in my office, breakdowns. We might naturally ask ourselves, what is wrong with that person? Trauma-informed care is really about saying, what happened? Why would a person behave that way? I think one of the biggest frustrations that I've seen from my medical colleagues is frustration. Like, oh my gosh, I keep telling this patient the same thing over and over again. How many times are they gonna come in, not listen to what I recommend, and then have the same symptoms and then keep coming back for the same symptoms? If we ignore trauma in our practices, what we're gonna end up doing is doing the same work over and over again without having a different outcome.
I mean, our experience as providers has changed from being overwhelmed, from having a chaotic clinic, to an experience where we're feeling like we are doing the absolutely best job possible.
People come willingly. They're using more services, so they're understanding that their health is not just that medical service, but it's what they eat, how much you move, and the state of your soul.
But what we've seen is people kind of having longer periods of stability, and maybe they slip, but they get back in touch with us more quickly than they used to.
Once you start communicating where you're not being dictated to, you know, someone is actually asking you, how do you feel about this? And how, you know, it builds that trust. You know, it's like, wow, they actually heard me, you know, and I see it.
Talking about and becoming trauma-informed does not have to be a traumatic experience.
This change process is incremental, and you can begin this as an individual person in your clinic and make a meaningful difference, not only to your patients, but to you as a practitioner. It's not radical to think that our job as primary care providers and why we went into primary care in all of our different disciplines is to actually help patients heal. I mean, that's not radical at all. It's self-evident, but it's like taught out of us. And what we're doing now in this movement towards trauma-informed primary care is to teach that back in, is to help people realize that their vision for why they went into this to begin with is to help people heal and to connect with them in that process, and to heal themselves in that process, and to have joy in that process.
All right. I really love that video. I think it just describes trauma-informed care in such a beautiful way. And moving right along to our next slide here, I want to know how you felt about that video. Oops. So how can you use trauma-informed care in your screening and messaging, especially when talking to survivors of intimate partner violence? Go ahead, throw some thoughts in the chat, throw some thoughts on your Slido. Try to get the patient alone. Yeah, definitely. You bring up a really good point. We want to make sure that we're screening patients alone, just in case the perpetrator, the person who's hurting them, is there with them. Meet the person where they're at in that point of time. Yeah, that's awesome. And I think of this, meet them where they're at emotionally, but also meet them where they're at physically. So like if they're sitting down, you can sit down as well and speak to them face to face. Make it easier to ask questions, but also ask the difficult questions. We'll talk a little bit about that. Become trained. Yeah. And in the chat, we've got a couple. Let's see here. Make them feel safe. Great. Listen to them, build rapport. And I think what that trauma-informed care is really trying to do is help you build trust with your patient. So great. These are awesome ideas. So I want to just talk a little bit about screening, messaging, resources, treatment. This slide was created by Kathy Franchek from the Utah Domestic Violence Coalition. So just talking about screening first, there are different ways that we can do it. And one is screening directly. So the direct method would be, of course, asking the patient when they're alone first. But would be saying something like 1 in 3 women in Utah will be in an unhealthy relationship at some point. This is why I ask all of my female patients about their relationships. Be aware that some of the things I may tell you, I might have to report to law enforcement. And then you go through all of the different questions. Have you ever been strangled or choked by a partner? Have you ever been humiliated or emotionally abused by a partner? And et cetera. You go through the questions. An indirect method could be many people will experience an unhealthy relationship at some point in their lifetime. Those types of relationships can really affect your health. And we want to make sure that if this ever happens to you, you know that you can come here and we can help you. And then, say you've screened directly or indirectly, and you're still not sure if someone is understanding you or you're still suspecting intimate partner violence, you can rescreen. And you can say things like, sometimes an unhealthy relationship can interfere with your health. Is this happening to you? And then once you screen, regardless of what the patient says back to you, if they screen positive, you want to make sure that you're affirming them and you're saying things like, thank you so much for telling me. I believe you. I'm here to help you. Other women in my clinic are experiencing this as well. I can help you. So again, you're bringing it back to not that this should be normalized, but you're normalizing it to the point where you can say to them, I'm a safe space, I trust you, and I can help you. And then if your patient screens negative, you also want to respond in a positive way. I'm glad that you're in a really healthy relationship. If you ever, or if any of your friends are ever in this situation, you can come back here and we can help you. And then from there, you've created that trust. You want to assess for danger. So there are certain steps that you can go through. For the state of Utah, you can call the UDVC link line. And I know these resources here are very small. We'll have them larger at the end of the session so you can see them a bit better. But you want to reach out to your resources. Assess for immediate danger. Is the person that's abusing you here in the waiting room? Are they around? Do you think they're coming? Is the location set on your phone so they can track you? Things like that. And then you're reporting, you're connecting the person to these resources, and then they're creating the plan from there. Sometimes you might have to report to law enforcement. So in the setting of an intimate partner violence, if you're treating an assaultive injury, if the patient was threatened with a weapon, if the partner threatened to kill the patient, if the partner is on site and you feel unsafe, if you as a healthcare provider feel unsafe based on what you've heard, or if a child witnessed the domestic violence, these are all mandatory reporting entities in the state of Utah. So you will have to call with your law enforcement where the assault occurred. And then again, treat life-saving, any immediate life-threatening injuries first, and then from there you can treat other injuries. And another infographic that I found from the National Network to End Domestic Violence, again, this is specifically referencing COVID-19, but I don't think it just applies to COVID-19. I think it's a great resource overall. And this is just tips for helping a friend or helping anyone, honestly. And what I love about it is that it involves that trauma-informed care. So you're asking someone, how do you prefer to connect? And you're giving them that control. You're, saying, let's stay in touch. Let's have a call with the kids. Let's play a game online. You're supportive and you're showing that you care about them. You help them think through how to stay safe by saying, maybe we can help you create a plan if that's something that you're interested in. And then also help them find a local domestic violence helpline. So like I said, in Utah, we use the UDVC link line, and we'll talk about that a little bit later, and I'll show it to you on the slides. But again, these are just tips. We can't prevent violence in the future. This is definitely the first step to that, but it doesn't mean that we can force someone to leave their abuser. Jamie will talk about this a little bit later, but just with the cycle of abuse, again, these are tips, and we're hoping that through this presentation, maybe you can try them with some of your patients. So what are some other tips for helping a friend or any person experiencing domestic abuse? Go ahead and throw them in the chat, throw them up on the Slido. Looking in the chat here, work with your forensic nurses. 100% an amazing resource. Believe, showing support, being there. This is great. I'm actually going to just skip through so we can get to the strangulation part and the lap. And Jamie, if you want to take over.
Yep, I'm going to get this. Just requesting control from Allie. Okay, so we just want to talk a little bit about strangulation. It's something that we, especially as healthcare providers, especially those at emergency department and EMS, are going to probably see. We're going to see probably the day of when it's happening, where if you're in a primary care clinic or something like that, you might see it later on. You might see the after effects, but this is the definition. So again, it's causing reduced blood flow to or from the brain. The application of only 4 pounds of pressure occludes the jugular veins, and 5 to 10 or 5 to 11 occludes the carotid arteries. So remember that only 50% of all strangulation survivors present with visible injuries. So it is very important to do the screening for this. And if you're in the emergency department at the U, we actually do have a protocol for this of what testing needs to be done. Really, all of these folks need a CTA because you might not know the injuries that they have. They can have a stroke later. And so we'll kind of go through this, but realizing that they also might have some secondary amnesia, and then, they have a traumatic brain injury at this point in time. They have an anoxic brain injury from being strangled, and they could have been strangled multiple times. So thinking about that, and we'll talk a little bit later about people's response to trauma, how it is not typical. It's not maybe the way that we would expect people to respond. Let me see if I can go to the next one. There we go. Another thing I like you guys to see that as of 2017, strangulation has been added to the aggravated assault criminal code. So this does need to be reported. And it is aggravated assault at this time. So again, applying pressure to the neck or throat of a person or obstructing the nose, mouth, or airway in a person. So any act that impedes the breathing or circulation. So unlawful force or violence. So just like, this is just the Utah code, Amanda. So I'm not sure if other states have had that, but this is our Utah code. Looking at this, so consequences, trauma. So carotid artery dissection, people can have a stroke. Again, we talked about anoxic brain injury, unconsciousness, death. Death can happen within 2 minutes of being strangled. And Allie and I were talking about this earlier. The act of strangulation isn't to kill someone most of the time. The act of strangulation is to show someone that you can kill them, that you do have their life in their, your life in their hands. So it is what you can or can't see. And like I said, some people can be strangled multiple times by their partner and they're not showing any symptoms. But if they do disclose this, it is very important that you talk with your providers and get the correct imaging. So looking at this as symptoms. So if they have a hoarse voice, normally you can see bruising around the neck, abrasions around the neck, petechiae, subconjunctival hemorrhaging. You can see, sometimes you actually do see finger marks on their bruising. So look for patterns. Even if they're not disclosing, if they come in with maybe some of these signs and symptoms of strangulation that, but they're not disclosing that, we look for these type of patterns, that we look for that. And then and again, it's in the messaging, is understanding that strangulation is very detrimental. It can cause a lot of side effects. Keep it based on their health at that point in time. You want to create that safe space, but you also want to let them know that you are concerned about their health. And yeah, so like Allie says, yes, it's not always there that you see these bruisings or the hemorrhages or anything like that. So I want to show a couple other pictures here that's a little bit real time. So you can see the I can't say it today, subjunctival hemorrhage. These are non-fatal strangulations, obviously. So this can be pretty severe or just mild around the eyes. Another thing you can have is mucosal membrane up under the lips. And you can also have a little bit of petechiae behind the ear. So these are maybe some subtle signs that you can look for. If somebody's disclosing that they have strangulation, look for these things. But even if they don't have signs, like I said, advocate for a CTA. Again, because a lot of these times they can have that carotid artery dissection, or they could end up having a stroke. And so it's always good to have that imaging done and get that taken care of. And again, you want to promote a safety plan. So one thing that we talk about is safety planning. Safety planning is not something that you as a first line provider need to plan. You don't need to come up with the plan with your patient. If you're in the emergency department, if you're in EMS, but knowing what a safety plan is and promoting getting a safety plan is very important. So again, we talked about the cycle of violence. So it depends on where a person's at in their relationship. They could be in the honeymoon phase where everything is great. They could just be starting to see red flags. They could have already gone through the cycle of trying to leave and going back. And it is very hard. It is definitely a cycle. And some people, as Kristen Hall has said, it's better than the hell that you know than the hell that you don't. It's very scary. And when you have somebody that's controlling every aspect of your life, they can very much make you feel afraid to leave them, feel shameful, like everything is their fault. So it's really hard. And so it's really our job is to connect them to those resources and promote having a safety plan. So when they are ready, when they're in that space, when it's time to go or get out of that relationship, which is the most dangerous time for anyone in intimate partner violence relationship, is when they attempt to leave, is helping promote and get them to resources for a safety plan. So this is just, again, imaging recommendations. And I know this is very, very small for non-fatal strangulation. So again, it's evaluating those carotid and vertebral arteries for injuries. What is really important is, to get that imaging done, evaluating the neck structures, and again, evaluating for an anoxic brain injury, especially if this has happened multiple times. They are going to show signs of that. So it is very important that you know or have imaging recommendations and that you're advocating for those. All right, so we're going to go on to this video. So we're going to focus now and kind of turn attention to the EMS side of this. So how many of you guys out there are EMS providers? I know a lot of ER folks that are on there and trauma folks, but how many of you guys work EMS? You can just put it in the chat. Let me get my time frames on here.
All right, 68-year-old male, chest pain, cold clammy.
I'm going to get this up to the times where I want it.
Maybe no one mentioning
trauma
that they're from EMS yet, but I imagine we have a couple.
Boyfriend shot female and ran off.
The victim, Melinda Soria, a mother of two, died before Sunstar ever left its hub.
It's not always about the dramatic saving life and shocking and stopping the bleeding. More often it's, hey, you know, there's this resource, or there's you know, these ways to make your life better.
Unlike the dramatic scenes you see on TV, first responders save lives in the quiet moments too, asking questions, sharing resources that can set someone on a new path. They couldn't save Melinda, but there are countless others like her they will help before it's too late. All thanks to a unique 4-year partnership with CASA, the state-certified domestic violence center serving St. Pete and Southern Pinellas.
We used to sponsor Susan G. Komen, and we found that our employees to whether somebody is going to be able to walk away from that.
There we go. Responders
are the key to whether somebody is going to be able to walk away from that situation or find themselves lost and going back into it. When you call an ambulance to the house, now we're getting to a place where you cannot ignore the fact that this is a violent situation and you need help.
Sunstar's crews are trained to recognize signs of abuse, silent ones they might have missed before the training with DV advocates.
If you read body language, you start to learn on how to pay attention to the minor details, and you can kind of, you know, read people and their body language and kind of see what they're saying, even just little gestures they can do with their face or their eyes.
You're taught to really take in the whole environment. We're lucky that we can actually see everything around us, unlike the hospital or the doctors and the nurses. When the patient gets to them, all they see is them, the injuries. I can see, you know, the drugs sitting on the table, or the disarray that the house is in, or the behavior of the family that's in that home, you know, as opposed to somebody in the hospital that doesn't get to see the whole picture.
And they're also trained to be patient.
Most people think, you know, you have to leave right now, or and it could be a life or death situation if they don't leave that day. But I couldn't imagine picking up my whole life and just leaving that day. A lot of times they're not ready for that, and I don't blame them. So being able to leave resources with them, or a discreet message to let them know, hey, there's help when you're ready, when you can line things up, hopefully they make it to that day.
That's why it's important to train first responders like the Sunstar paramedics, because when they come there, this may be their 3rd or 4th time coming there. Somebody who's not trained is going to be frustrated, they're going to be angry, and they're going to be professional, but there's going to be a little edge to them. When that person's been trained and they know it could be up to 6 or 7 times before this person leaves, they're going to come with the same amount of compassion they had the first time out.
And that first of its kind training is changing.
Okay, so that's one thing I really want to touch on, is the fact that all of us deal with people who maybe we have seen 3, 4, 5, 10 times. You even heard it in the providers talking about it in trauma-informed care. And education really is the key, and training really is the key to be able to approach each time, especially if they've disclosed to you in the beginning that this is a violent relationship or unhealthy relationship, and you continue to come on there. The best thing you can do is respond with compassion each time, offer them resources each time. I read a study, there was a couple of disturbing results in the study, but I'm only going to share one, with EMS providers, and this was published in 2018 in an EMS 1 publication. And they did some training, so they did some screening training, domestic violence training. And when they asked folks if they felt like if the person didn't disclose, they could still make a difference, 46% said that they did not feel like they would be able to make a difference if that person didn't disclose. And that's where I would really like everybody, I think everybody on this call and in that situation, to hear the message that you can make a difference, even if somebody is not disclosing. Like Ali spoke of with the trauma-informed care, with messaging, with screening, letting them know if you are ever in an unhealthy relationship, or if you know somebody that's in an unhealthy relationship, you can come and talk to us. We can give you help. Or even letting them know, people that are presenting with similar symptoms to you or the same symptoms as you, or people who are calling us multiple times as EMS providers to come to the scene, sometimes are in an unhealthy relationship. And I would like you to know, if that's the case, we are able to offer you resources. So this is kind of what we talk about. So the lethality assessment program is a Maryland model. It's one of the screening tools that is used in Utah and promoted by the Utah Domestic Violence Coalition. I am a trainer of this program. The law enforcement is who uses it right now. We would really like to get it out to our EMS providers are trained to use this in collaboration with our mental health providers in the community, because you do need that partnership. But one thing that I like about that is it is evidence-based. They have done studies. There is evidence that this referring protocol and this program can assess high danger victims. So it's very important that you're seeing the fact that these, high danger victims are the ones that you can make the most impact on when you are in the first responder world. Or again, like they said, in those quiet times in the videos of just asking the questions, being aware. So if domestic violence homicide is predictable, which this says that it is because you're screening them for risk factors, it is preventable. So we can prevent some of these things just by being aware. And again, you might not be able to see this very well, but this is the screen, and it is, again, based for law enforcement, but it's questions that you're asking. And then on the other side, it talks about the likelihood of lethality. So the percentage of increase if they are answering yes to these questions. So it goes up dramatically if they have used or threatened with a weapon, if they've threatened to kill you, 9.9% if they've threatened to strangle them. But please understand that if they have been strangled already, they are 800% higher risk for homicide after that point in time. So threatened brings up their risk to a higher risk, but if they've actually been strangled, they are 800% times more likely to be a victim of homicide after that point. So knowing when to ask these questions, if EMS providers especially are usually, if it is a straightforward domestic violence call, intimate partner violence call, they are responding with law enforcement. And each law enforcement agency has their own screening tool or method that they use to screen, but it's those calls that are the abdominal pain, suicide patient, maybe just anxiety, that EMS is going on by themselves, not with law enforcement. And that's where the training comes in and kicks into play, is that you are thinking about these questions, you're thinking about looking at the whole environment. And so that you're like, hey, I really need to ask these questions and maybe contact law enforcement. Screening tips, talking about that, especially with the lethality assessment program, it's redefining the normal. And I know that we're getting close to the end, so I'm going to try and just go through this fairly quickly. Hopefully you guys can stay on with this just a little bit longer. It is a lot of information. So it's redefining normal. So we've talked about many times how people who are experiencing trauma or acute stress disorder, they no longer respond in what you would consider the traditional way. So they might be more jumpy, they might be more irritable. They're in fight or flight constantly. It's exhausting to be in fight or flight just for a day, or even if someone just scares you. But they are in that fight or flight or that PTSD, and it is rewiring their brain. It has an impact physiologically and physically in their system. So understanding that it is not just in their head is what people say. This is something that is actually changing their wiring of their brain. That can change and that can go back to normal with help. But again, they could just be sitting there. They could be non-reactive. They could be completely flat affect. They could be completely bawling, hysterical. It's not predictable. And it is conducted on people who are experiencing trauma. So any screening especially something like this, is conducted on somebody that is experiencing or has experienced trauma. I'm going to read this question in the chat real quick. Assessment or preventative measure that address the perpetrators of abuse rather than keeping the responsibility on the victims. No, that is something that I would like to see more of. And I think especially those people that are working with intimate partner violence and domestic violence, there is a spot in, Davis County, I believe, that does bring these perpetrators into a program. And that's why I said it's got to start with understanding why they're perpetrating in the first place and trying to give them help, trying to help both people understand what a healthy relationship is. So sadly, unfortunately, it is the responsibility on the victims to leave that relationship right now, but it absolutely needs to be a future focus on the perpetrators. And one, we ask, what happened to you to get you to this space? And that is a very unpopular view. That's not something people want to talk about. Some, is helping the perpetrators as well. But if we can't help the perpetrators, they're not going to stop. And again, like Ali just said, focusing on preventing ACEs. So we'll do that. So just remember that, and this is just asking, so just think about it in your head. What kind of common trauma reactions have you seen? And understanding that everybody responds differently. So we talked about these resources. So we've got the Family Justice Center, we've got the Utah Domestic Violence Coalition, Victims Resource Connect, other things that you've seen us take information from. We've got the CDC, violence prevention and intimate partner violence. You also have the Utah Department of Health Violence and Injury Prevention Program. You've got Veto Violence. So there's a lot of different victim-centered resources that you can give people. And we will actually have a resource booklet for healthcare providers and a badge card that has these resources and things on them. If you want one of these, they're in the process of getting to print. Please let me know and I can send that to you. And like Ali said too, focusing on preventing ACEs. So another thing that EMS is, again, it doesn't look like we have any EMS providers on there, but if they're watching this later on YouTube, they're in a unique spot to be able to maybe see that children are in the home. And help get people to resources. And hopefully that brings it back to that primary prevention so they can help create a better environment for those children and lessen the impact of those adverse childhood experiences. All right, so this is our intimate partner violence series. And is this just Ali, I didn't see.
Yeah, I threw the actual link to the playlist in the chat. This is just a little loop of it though.
Okay, so we're gonna just play a quick blurb of this, because I love listening to Kathy. I love listening to Dr. Franchek.
My name is this is like one of the videos, but
full of video. Okay, yeah. We probably can't go through the whole video there. No. This is one of the times I think she talks about the fact that it is their response and what it does to your amygdala and the change in your brain that actually happens in PTSD and the trauma response. So if you have a chance, get on that link that Ali sent and watch that education series from August 11th, 2020. Dr. Franchek is amazing. Just watching her present is always amazing for me, and it's a great resource tool. All right, so luckily we kind of went through that really fast as Ali is launching this Slido poll. I would love to open it up to see if you guys have any questions, any comments. And again, this is how we need everybody to answer this question at least so that you can get your certificate.
In the emergency room, when patients say yes to the violence and everything, it doesn't trigger a page to social work or anything like that, right? It's just our responsibility to talk to the provider and then connect them to get the resources.
Yeah, so if they are admitted, it will trigger a referral. As well, if they're suicidal, which is kind of, you're talking about the same thing, admission can, but in the emergency department, no, it doesn't trigger any sort of automatic referral. Usually only if they're suicidal does it trigger that.
Okay.
So it is very important to get with social work. Again, try and find a way to interview a patient alone if possible. And then it's the same kind of thing. It's using your best instinct or your judgment, even if they don't disclose, but you have a concern. It doesn't hurt to say, hey, I'd like social work to come and chat with you if you're willing to, and let them do their own assessment too.
Okay.
And Jessica, if you, the emergency department at the U, the educator's name is Zoe, if you haven't met her, and on the ED education homepage, and then also if you speak with Zoe, there are outlines of what exactly to do. It kind of walks you through the process. So I encourage other facilities who have joined to do that for your own departments. You know, if you're not in the state of Utah, or you're in an area that is more rural, that doesn't have access to certain resources, just to kind of make a framework and an outline for your facility, for your staff, to help them learn and understand exactly what to do if this happens.
Thank you.
Another thing that I liked that you can go to is 211.utah.org. And that is something that you can, if you're in the emergency department at the U, you can add this to your discharge instructions. You can have the providers add it to your discharge instructions. And sorry, I just threw that in there. This is something that you can give that has every resource possible: housing, where the free clinics are, where they can get 24-hour medications, but it also includes those other link lines. So this is something that you can utilize, and it has a list for all counties in the state of Utah. So you can pull up your own county if you want to just give this to your patients when they discharge, and just say, hey, I just like to give everybody this resource paperwork. It has all the resources in our county that are available to you. And that doesn't float or, shoot off any red flags if they're perpetrators with them, and say, oh, well, they're giving them domestic violence resources or something like that. So it's a great, thank you, Allie, for putting that in there. It's a great resource to utilize throughout the state of Utah, and other states have the same one. It's usually Utah, 211 with the state. So if you're out of the state, you can look up that same resource, and it has those things. All right. Anybody else have any other questions, any other comments? I know we went through a lot of information really quickly. And again, just put our little toe in the water as far as things that you can talk about on this topic. Okay.
Thank you.
Thank you.